I would like to start off by thanking the organizers for being so flexible and accommodating and helping us all to have an excellent meeting experience. And I wish I could be there with you all in person. I'm also thankful for the invitation to give this talk on the topic of whether or not amyloid should be targeted in Alzheimer's disease. I have no relevant disclosures for this talk. The objectives are to be able to discuss considerations of the current Alzheimer's disease therapeutic landscape, review the brief history of Alzheimer's disease, explain Alzheimer's disease as a biologic process, and describe the relationship between beta amyloid and Alzheimer's disease, which is key to making decisions about whether or not it should be a therapeutic target. We'll do this in 4 sections, beginning by considering the current AD therapeutic landscape, going into a brief history of Alzheimer's disease, discuss the importance of considering Alzheimer's disease as a biological process, and then conclude with a discussion of whether or not beta amyloid causes Alzheimer's disease dementia. So we'll start with the current therapeutic landscape. So the current management of Alzheimer's disease is mainly symptomatic or supportive, but once again, the interpretation of that comment depends on your understanding of mechanism. But it's typically this is true with lifestyle, treatment of concurrent disorders, medications such as cholinesterase inhibitors, non-medication support, and most of the resources and infrastructure to managing this disease are geared towards these current approaches. What is clear in this current landscape is that there's a deep and shared desire for additional options. This is true for clinicians, researchers, patients, caregivers, regulators, and all involved. Those options that many are looking for do involve disease-modifying therapies for Alzheimer's disease. There's certainly other options, which we will not be talking about here today. And the aim of these therapies are tacked on the disease process to slow it, stop it, or reverse it to improve its effects on cognition. And this current moment is really uniquely exciting, but also challenging, given the current state of the science with additional options available to us, including molecular therapies targeting different models of the disease process. And in this regard, the emerging anti-amyloid drugs are the current point of focus for this talk. So there are several anti-amyloid antibodies in late phases of clinical trials. As we all know, Aducanumab was approved by the FDA in June of 2021 for potential use in mild stages of symptomatic Alzheimer's disease. So the focus of this talk will really be, is amyloid a reasonable disease-modifying target for AD dementia? Some of the guiding studies in this regard revolve around the amyloid cascade hypothesis, and that amyloid accumulation is an early step in the cascade that leads to dementia. There's many supporting features to this, including postmortem neuropathology, longitudinal biomarker studies, genetics, and the rare familial cases, APP, presenilin 1, presenilin 2, and trisomy 21. In addition to models or in vitro studies suggesting toxicity of amyloid, there's certainly many active questions. There is no mechanistic link between amyloid and tau, and we'll talk more about this throughout the talk. There's also a striking spatial and temporal disconnect between the evolution of both amyloid and tau and the development of cognitive dysfunction. And it's been well known for a long time that amyloid positivity occurs well before symptom onset. So some broader questions in this setting. Is amyloid a viable strategy to prevent, halt, or reverse cognitive decline in symptomatic AD? Does the timing matter? Does this need to be in the pre-symptomatic phase, early or late symptomatic? Does this have an influence on the clinical response? Is amyloid targeting in and of itself sufficient in the treatment of Alzheimer's disease? What about other elements of the Alzheimer's pathway, including things associated with aging, tau, inflammation, functional connectivity, and other processes? Might combination therapy be the best approach as is the case in other complex diseases? Might precision medicine become increasingly important? So to briefly review Aducanumab, it's a monoclonal IgG antibody. It stimulates microglia to primarily clear amyloid plaques. The phase 3 trials included folks with MCI and mild dementia that were amyloid positive. Requires monthly infusion over 18 months, maximum 10 milligram per kilogram with titration. Originally, these trials were halted in 2019, given concerns about futility. Reassessment indicated there may have been a response in the eMERGE trial on the primary outcome of CDR sum of boxes. Whereas in the ENGAGE trial, there remained no difference in primary outcomes. There's been proposals that different exposure to the high dose explains the difference in the outcomes. But there are several sources of discussion and debate regarding placebo group differences, disease heterogeneity, primary versus post hoc analyses, and the impact on biomarker status and whether those are related to the cognitive outcomes. This in the setting of many other prior studies showing negative results with this therapeutic strategy. There's also a wide discussion about cognitive outcomes and clinical meaningfulness, which will become increasingly into focus, and certainly the side effect profile. So some important details about the FDA approval is for mild symptomatic stages, MCI or mild dementia. And there's not currently a specific comment about biomarker status, but there is broad agreement in the field that establishing this is critical. And the recent CMS decision reinforces that, requiring amyloid biomarker status. Approval was via the accelerated approval pathway based on effect on a surrogate endpoint, namely amyloid lowering, that is reasonably likely to predict a clinical benefit. Once again, that involves causal reasoning, which we'll get to at the end of this talk. But there remains some uncertainty about the drug's clinical benefit, which is why the FDA indicated a need for more clinical data on efficacy. This appears to be reflected in the recent CMS decision requiring participation in clinical trials for coverage. And there are non-trivial potential side effects associated with the treatment. So when thinking about these various trials, one size obviously does not fit all. There's many plausible variables in these different clinical trials regarding target mechanism binding with agents like Aducanumab targeting more the monomer phase of A-beta versus Aduhelm and related agents targeting oligomers, and Aducanumab or BAN2401 targeting the protofibrils. These certainly would all influence potential outcomes. In addition to brain penetration, pharmacokinetics, the pace of amyloid clearance, timing, duration, follow-up interval, and the clinical syndrome of the individuals included in the trials. So when we had originally looked at the data in the summer of 2020, it was clear to us at that time that there was not demonstrated efficacy in the emergent and engaged trials when considered that the primary outcome was of both studies, and that logically the negative outcome in engage is likely to be giving the true message as is the positive result in emerge. One thing that we think is important, and we noted in this opinion piece, was that the high person-to-person heterogeneity and progression plays a role in interpreting these clinical trial results, and I'll get more into that in a second. We thought that there was some compelling evidence, and a third trial seems to be a reasonable place for this agent. Just this week, we got an announcement from CMS and in terms of their memorandum on the national coverage determination, and they are recommending coverage with evidence development. We're calling for exactly such a clinical trial, and it will be covered in that respect. And this is currently open for comment. So back to the syndromic variability playing a role in clinical trial outcomes. There's this excellent recent paper published in Neurology, which looked at the ADNI data, assuming that there's some fast decliners and slow decliners within the therapeutic population. If that's not accounted for in the randomization, how that may impact trial outcomes. You can imagine a perfect balance where that would not, you get the true treatment effect versus an imbalance, oversampling fast decliners, you would underestimate effect, versus oversampling the fast decliners, you would overestimate the effect. So in this case, they actually randomly sampled 10,000 different times, dividing ADNI participants into a theoretical placebo or treatment group and seeing the range of trial outcomes in these simulations. What you can see is there's a large amount of heterogeneity, and not accounting for that in the randomization can lead to spurious conclusions, as shown here. And recent clinical trial results are contextualized in regards to this heterogeneity. I'll outline a couple of them here, where this gamma secretase inhibitor, a different class of medications that are monoclonal antibodies, still impacting the amyloid cascade, was halted given its clear demonstration of potential harm, versus the emerge trial, the positive ADUHELM trial, versus the negative one engage, versus other similar medications in this class like solanezumab or bapineuzumab. And then the recent phase 2 trial, donanemab, around in the same region. So the important thing about the interpretation of these results usually revolves around if we could enrich for fast decliners, or people in which it would be easier to demonstrate an effect. And if you did that based on tau status, this problem of heterogeneity does not go away. It actually is increased. You have more heterogeneous outcomes if you condition on tau positivity or on ApoE4 carrier status. So given that current landscape, let's step back and briefly review a history of Alzheimer's disease. So we'll zoom through this, but going back to ancient times, there's this point in life, sometime in the after the mid-60s, that was referred to the senile phase of life, where the term senile dementia comes from. And cognitive decline was considered an inevitable part of aging in this phase of life. These two pieces of information give us our first two pieces of the puzzle, talking about cognitive decline and its age-associated. And I'd like to talk about age-associated diseases. And in this common argument, we hear that sometimes it's an inevitable part of aging, therefore it's futile to manage or treat. However, there are many age-associated diseases, and none of them are treated in that way. And I don't believe dementia should either, including atrial fibrillation, diabetes, etc. And so there are certainly many age-associated diseases highlighted in this recent review from some colleagues at Mayo Clinic and the Kogod Center on Aging, including stroke, sarcopenia, macular degeneration, diabetes, osteoporosis, etc. There are many cellular and molecular hallmarks of aging, which certainly can interact with all of these diseases. And considering other age-associated diseases, there are many potential pathways to a common outcome. And considering osteoarthritis, that common outcome is joint dysfunction, many pathways to that joint dysfunction. You may want to target specific pathways to that joint dysfunction, although there's a direct intervention on the common pathway of joint replacement. We don't have this option in dementia. But you can certainly consider Alzheimer's disease and dementia in general as a complex disease and take a systems-based approach. There's this excellent article in response to the NIA research framework discussing a systems model of Alzheimer's disease. Interventions could occur at these many pathways stage versus the common pathways stage. I think that's important to consider. So the key points I wanted to make here are that age-related diseases are manageable and need not be dismissed as inevitable consequences of aging. Age-related diseases are complex with unique and common causative pathways. Markers of these causative pathways can inform management, and AD biomarkers can be thought of as a marker of the particular Alzheimer's pathway to the functional state of dementia. So returning to our brief history here, getting past our inevitable age-related cognitive decline to some causes, which hardening of the arteries is one of the early causes of senile dementia. But we'll talk, this is not the pathway to dementia we are discussing when we're talking about Alzheimer's disease. And in fact, Alzheimer gave us the markers of the pathway of the disease which bears his name. When looking at Augusta D, he noticed these characteristic plaques and tangles. So these are the elements of the pathway to dementia, we refer to as Alzheimer's disease. And Emil Kraepelin noted, while the anatomy suggests that you're dealing with this senile dementia, there's something different about this that we want to mark with these amyloid and tau, and the fact that it actually occurs in the pre-senile phase made them realize this was a distinct disease from what was referred to as senile dementia. Work then linked these pathologic findings in some cases of senile dementia with these pre-senile cases, and this gives us the continuum across pre-senile and senile phases. And dementia was then associated with plaque scores. And largely, many associative studies have redemonstrated this fact, but lose the distinction between association and causation, and that psychological and pathological indices being closely related means that there could be some common underlying degenerative process in the brain leading to that. And once again, our causal diagrams can get at those underlying processes. Many work, De Leon then used neuroimaging in this way to unite these findings. We start to include the acetylcholine dysfunction. Amyloid beta and tau are isolated in these plaques and tangles. We now know the proteins involved, A beta and tau. And then with the genetics in the late 80s and early 90s, strongly related to that protein, A beta, the amyloid hypothesis really took hold. Mouse models of this hypothesis were developed, and interventions on these models lead to benefit in these models. However, in human trials, these have all been disappointing. There's certainly other factors which I'm leaving out. So after getting this background and talking about a brief history of Alzheimer's disease and how we got here, I want to emphasize the current concept of Alzheimer's disease as a biological process. So there is this common association with of all these factors with some underlying degenerative process. What is that process, and why do we call it Alzheimer's disease? Well, the historical concept was that Alzheimer's disease was this clinical pathologic entity. You could have a clinical syndrome of a slowly progressive amnestic dementia syndrome, which would then predict the hallmark markers, plaques and tangles, and this is what we referred to as Alzheimer's disease. This is from the McCann criteria in 1984. So we're clearly focusing on cognitive decline that is associated with plaques and tangles. And in reading the clinical criteria, they make clear that they're not talking about any cause of cognitive decline. They're talking about degenerative cause of cognitive decline. So non-degenerative causes do not meet the criteria for Alzheimer's disease. But they also were aware that there's multiple degenerative pathways to this cognitive decline. Many of them were not considered Alzheimer's disease. In order to consider a degenerative pathway Alzheimer's disease, you would need to see those hallmark amyloid plaques and tangles. So this is kind of where we were in 1984. A large shift came when we started thinking about this more as a continuum, when MCI pushed this point from dementia further back. But MCI also acknowledges multiple pathways to MCI. You could have non-degenerative pathways. You could have Alzheimer's pathways to MCI. You can also have non-Alzheimer's degenerative pathways to MCI. So we still haven't isolated that green arrow. That was the goal of the 2018 NIA Alzheimer's Association research framework, to try and isolate that green arrow from the black or the non-AD degenerative pathways to cognitive decline. And so this does require biomarkers, especially if you're looking at that pathway before clinical symptoms are present. And amyloid imaging is very closely associated with pathologic staging of amyloid plaques, going from thal phase 0 to 5. Here's an example in vivo amyloid PET scans showing this progression. I will note several times that this amyloid distribution is throughout the brain, particularly in heteromodal association cortices associated with high levels of connectivity. And it does not recapitulate focal patterns of degeneration. like atrophy or tau does. So when you look at markers of degeneration like FDG PET or tau PET, you see a much different distribution, which closely follows the clinical profile. If you look at an amnestic case versus a language predominant case, you see language areas more affected with amyloid and tau, with FDG and tau, whereas there's no difference in amyloid PET in these syndromes. Visual syndromes, you see tau associated with the occipital cortex. And in disexecutive presentations, you see the heteromodal association cortices throughout temporal, parietal, and frontal regions. So that ATN framework gives you now names and ways to classify that entire Alzheimer's degenerative pathway in the clinical and preclinical phases. In conceptualizing AD as this dynamic biological process is really not a new phenomenon to medicine. It's very common. So you have biomarker status, you have clinical status, then you classify it. The biomarker is not there and there's no symptoms, there's no disease. If it's borderline positive and no symptoms, you'd say you're in a pre-disease state, but you're at risk. Where if these biomarkers are positive, no symptoms, that's preclinical disease. Biomarkers are positive, mild symptoms, that's mild disease. Biomarkers are positive, you have significant symptoms, that's severe disease. This is what the ATN framework reflects. Other models of other diseases similarly use this, such as fasting glucose in diabetes. So if the fasting glucose is normal and there's no symptoms, there's no disease. If you've got a borderline level of increased fasting glucose, no symptoms, this is considered pre-diabetes. Whereas if fasting glucose is positive, there's no symptoms, you still do consider that diabetes. Whereas if it's positive and there are mild symptoms, maybe without end organ damage, but other symptoms, you get to that mild, versus if there is end organ damage, that would then be a significant severe case of diabetes. And the ATN framework will similarly allow you to have those classes: no disease, AD, but with path change at risk state, preclinical disease, mild, and the dementia phase. So this framework requires only association and does not require causation. That's emphasized here. There's different ways to use these biomarkers in developing your causal models. Of course, what you see reflected in these diagrams is that cognition is at the end, and it's always preceded by neurodegeneration, because this is certainly a model of neurodegenerative causes of cognitive impairment and not non-degenerative causes of cognitive impairment. In particular, ones which that neurodegeneration is preceded by events related to amyloid and tau. So this tells us about a case who has dementia, and it is neurodegenerative, but there's no amyloid or tau. This is not an Alzheimer's pathway to neurodegeneration. In fact, this patient had hippocampal sclerosis at autopsy. And so biomarkers have allowed for a greater understanding of hippocampal sclerosis, or now what's called late disease, limbic predominant age-associated TDP-43 encephalopathy. So not only does the ATN framework inform us about AD pathways, it's teaching us about non-AD degenerative pathways to cognitive impairment. So we've now moved away from this historical concept to AD as a specific biological process defined by the presence of amyloid and tau. This does not require causation, and you can go from the pre-symptomatic to symptomatic phase. So the key points I wanted to make here are that AD biomarkers can be thought of as markers of the Alzheimer's pathway to dementia even before dementia has occurred. If amyloid is not associated with the AD pathway, then amyloid therapeutics need not be considered. However, holding this view is very difficult in the face of current evidence. If amyloid marker is associated with the AD pathway, then measuring it has a role in clinical decision-making independent of whether it's causative. However, the association needs to be of a causal nature on the direct causal pathway to have the disease-modifying role we expect it to have. So does beta-amyloid cause AD is the question we really need to answer from a therapeutic standpoint. These are some potential causative pathways involving NNC. This direct linear pathway, beginning with amyloid, has very little evidence. You can just look at pathology here, where tau clearly precedes amyloid. I will note, when you try to look at in vivo estimates of these, the sensitivity of tau PET and amyloid PET begins about here, and you can't see these early phases. So that's not an option. This detection threshold problem with biomarker models is in the updated Jack curves are there, where tau begins. So is this a reasonable pathway, a linear pathway beginning with tau with amyloid in between? There's really not a strong association between amyloid and neurodegeneration, so this is very weak evidence. In fact, you can completely remove amyloid and degeneration proceeds, as was highlighted here, 14 years after successfully removing amyloid. There's still the tau degenerative process occurring. However, there's not good evidence for a tau straight to neurodegeneration without amyloid either. You don't see the Alzheimer's clinical syndrome pathway where folks are tau positive and amyloid negative. So there seems to be some other pathway where you separate amyloid and tau and they converge. And people are commonly holding this type of a model, which is still consistent with all these facts that I just outlined, eliminating the other models, which this is probably the most common one that I hear. You have some factor leading to amyloidosis, some other factors leading to tau in the medial temporal lobe, but the tau in the medial temporal lobe cannot really get outside of the medial temporal lobe without amyloidosis, which triggers this, and then that leads to neurodegeneration and cognitive impairment. So this is the most commonly held model to fit with the evidence that we just reviewed in current clinical trials, not explicitly stated, but implied in most of them. However, you can certainly draw other causal diagrams, also consistent with the evidence I just reviewed, where amyloid is separated. Some of them, in fact, an epiphenomenon, some it's directly on the pathway. Some it's separated from APP, so you can keep the genetic data without invoking a direct toxicity of amyloid. And so all of these models are consistent with current evidence, including genetic evidence of APP, PS1 and PS2 mutations, but not all of them have a causative role for amyloid plaques. There's certainly other elements you could invoke, putting amyloid within relating to things occurring in synapses. And I have some models doing that, which I won't review in detail here. But there's certainly many other elements which you can put in these pathways that removes amyloid plaques or some of its species from a direct pathway. I won't review all these other elements, which you could also be putting in your causal diagrams related to ApoE, endosomal lysosomal network, and autophagy. But the bottom line is, you can certainly draw other pathways where both amyloid and tau are non-causative. This is one such pathway, which would be consistent with all the data, but knocking out amyloid and knocking out tau would still allow a pathway to neurodegeneration and dementia. Yet, even though that is true, tau and amyloid would still be excellent biomarkers of this pathway. So that gets us back to complex systems understanding. and interpretation of ongoing clinical trials. Where this two-stage tau model appears to be the most common one implied. They even note here that for the Aducanumab trials, fluoxetine PET screening criteria led to exclusions of patients with the highest tau levels, although they had to have some tau, because they're hypothesized to be more resistant to anti-amyloid treatments. So they allowed people in with some tau, but not too much tau because you couldn't intervene in amyloid at that phase. So this is the most common pathway, I think, applied. But if this is the causal model, you should see responses in these biomarkers, which we have yet to see. So the key points I would like to make are that age-related diseases are manageable and need not be dismissed as inevitable consequences of aging. Age-related diseases are complex with both unique and common causative pathways. Markers of these causative pathways can inform management. And AD biomarkers can be thought of as markers of a particular pathway to functional decline causing dementia, the Alzheimer's pathway. So AD biomarkers can do this even before the dementia has occurred. If amyloid is not associated with the AD pathway, then we should not be talking about it as a therapeutic or a biomarker. Holding this view is very difficult, and you really need to explain a lot of the evidence with some other model, and it's insufficient to just exclude it without doing that work of explaining the current evidence. If amyloid is associated with the AD pathway, strong evidence that it is, then measuring it has a role in clinical decision-making, which is how we use it currently in clinical decision-making, independent of its causality. However, the association really does need to be of a direct causal nature to accomplish disease modification with the anti-amyloid therapies, and this is clearly an open question. So should we continue down this road? It really depends on your model. And there are many potential models, and we explored some here today. So just a brief review of the talk. We considered the current state of AD therapeutics, reviewed a brief history of Alzheimer's disease, really emphasized thinking of AD as a biological process, which really is required for causal reasoning about our final question of whether or not amyloid causes AD dementia. It's important to note that in this regard, Aducanumab is just the tip of the spear. These promising phase 2 results from Aducanumab and other monoclonal antibodies. I think we really do need to conduct the trials to make sure there is efficacy when weighing the risks of these drugs. So all of these things can be true. Amyloid removal alone may not be a cure for AD. There are uncertainties on whether Aducanumab impacts clinical status. Anti-amyloid antibody therapies include non-trivial side effects. Amyloid removal alone may be part of management for some patients. Aducanumab may have clear benefits on clinical status beyond 18 months. It's uncertain. Some patients may have interests and qualify for the medication, and may benefit from counseling and shared decision-making. And our intentions in this regard, and we are considering the recent CMS decision, we would like to apply our unique expertise to guide patients in the field and to optimize care in this new AD therapeutics landscape. I hope you enjoyed this talk on whether or not amyloid should be targeted in Alzheimer's disease. I hope you enjoy the rest of your meeting. Take care.